Namaskar, dear viewers. So, welcome to today's session of Critical Lines podcast. And it is my great pleasure and honor to have with us Dr. Dalim Baidya. So, Dr. Dalim Baidya is a very prominent figure in Indian intensive care. Sir was initially at AIIMS, New Delhi for a long time, where he was professor of anesthesia and intensive care. And he has been responsible for mentoring many DM critical care students at AIIMS. Several students have been taught by him, and it's really great that he has done such wonderful teaching and produced such great intensivists who are on their journey in critical care. Now, sir is head of critical care at AIIMS Guwahati, and he's also the current co-editor of the Southeast Asian edition of Washington Manual. He has authored more than 200 publications, and he is an international faculty for various academic events. So, with that, sir, I think we shall start. So, today, dear viewers, I have just taken a case vignette, and we shall start with that. Sir will discuss the kind of management, etc., for that, and then we can subsequently take up a few questions. So, I'll just show you the. So, this is the case, right? A 25-year-old male is admitted to the intensive care unit with suspected meningococcal sepsis. Meningococcal sepsis, some of you may know, has a characteristic rash. And when he arrives in the ER, he has a lactate of 5 and a pulse of 160 and a blood pressure of 76 by 25, a CRT of 5 seconds. In view of this, he is intubated and a central line is accessed. He has been resuscitated with 1 liter of NS in ER and transferred to the ICU. His weight is estimated to be 72 kgs. He has warm peripheries and bounding pulses. So over the next 3-4 questions, Dr. Dalim shall discuss the subsequent management of this patient, which is a very, very common scenario. So I think it will be of interest to all of you. So, sir, here the first question now is regarding the use of fluids and vasopressors. There's a recent push towards early use of vasopressors now. It's supposed to
Right.
things, and if we achieve the blood pressure by giving vasopressors faster, it's supposed to help. So, at this point in time, he has received 1 liter of normal saline, and blood pressure is still low. MAP is not achieved. Would you like to push in more fluids and wait for some time before starting pressors? Or would you like to start pressure simultaneously and give fluids along with it? What will be your strategy here?
Right. So first of all, thank you very much for inviting to this podcast. So coming to the case discussion, this seems to be clearly a case of septic shock and probably meningococcal sepsis origin. So at this point of time, on arrival to ICU, regarding fluid and vasopressor strategies, my aim will be to initiate vasopressor as early as possible. So I would continue fluid resuscitation. 1 liter of crystalloid has already been delivered in the ER. So I'll continue simultaneous administration of crystalloids. Along with that, we'll initiate norepinephrine as my vasopressor of choice as at the first go itself, and will not wait for further fluid loading. However, consequence to that, we must understand that this early initiation of vasopressor is of late recommended, and it's a better strategy. We do not really nowadays follow that 30 ml per kg 3 hour proposal by the surviving sepsis campaign guideline, rather individualized fluid administration strategy depending on patients' various dynamic assessment methods of fluid responsiveness, as well as aiming the hemodynamic resuscitation targets. So, patient already is intubated on ventilator on has a central line. So, I will connect norepinephrine in the central line, take an arterial line as well. Continue crystalloid, remeasure lactate and capillary refill time both, and simultaneously titrate the vasopressor therapies. So in this context, I would like to mention that in patients who do not have a central line access, we should not wait for a central line to be, accessed to start initiation of vasopressor. We can administer from the peripheral line itself to begin with, provided it's a lower dose of NORAD and vein is a free flowing vein in a cubital fossa or above.
Great, sir. So you mentioned about starting vasopressor, sir. Now the heart rate is 160. So classically we start noradrenaline, and
Right.
does increase the heart rate.
Yes, yes,
Is
yes.
there a case here for starting vasopressin?
Yes, in this case, in view of excessive tachycardia, I would like to start vasopressin early. So, otherwise, also in septic shock patients with escalating dose of noradrenaline, there is a case for early vasopressin administration. It has found to be beneficial in, although not mortality benefit, but reducing the total duration of vasopressor therapies. So, vasopressin is a strong case because it can be considered as a part of multimodal vasopressor therapies, as it works by a different mechanism. It has certain other receptors, not the catecholamine receptors, the certain V1 receptors by which it causes vasoconstrictions, and at the same time, it will cause the heart rate to fall a bit in this clinical condition in this particular patient, and you will see the chances of arrhythmias are less, and probably the chances of AKI or RRT use may be less with early use of vasopressin, as it preserves the renal blood flow and GFR.
Great.
So yes, I will start vasopressin early.
Okay, sir. So now the admission lactate is 5 and the CRT is also 5 seconds.
Yes,
Now we
yes,
have started the fluids and we'll give the fluids, we'll start the vasopressors, but we got to monitor the perfusion. So we both have CRT with us, lactate also with us.
yes,
How would you like to use these markers of perfusion and resuscitation now? And
yes.
what is the utility in telling us about the prognosis, etc.?
Right. So, capillary refill time and lactate both have important values because both of them individually are important markers of microcirculation and tissue perfusion, and both of them has prognostic significance as well. So, either of them can be followed. However, each of them has got their individual pros and cons that we must understand in our clinical context in our own ICUs. So, if we take one by one, lactate has got few areas where it can be if provide a false positive values. Like if we leave out the other clinical context, even in a case of in a case of sepsis, so if the patient is on high dose of catecholamine, especially epinephrine, or if a patient of regional ischemias like gut hypoperfusion or a regional gangrene or so. Or patient with baseline liver dysfunction, in those cases, lactate will have a false elevation. So, we need to rule out such cases before we can solely rely on lactate. Uh, Otherwise, lactate is a good prognostic value, has got more research, and it is part of the definition of sepsis and septic shock as well. So there is a strong case of lactate. The other drawback is that you can't really measure it too frequently. Maybe you measure it hourly or 2 hourly basis. Otherwise, there will be logistic constraints. Whereas capillary refill time is a simple bedside method. It can be done very easily, and you can measure it as frequent as every 30 minutes and guide your resuscitation. But again, the cons of CRTs are that there can be subjective variabilities. So the amount of pressure we put, the nail bed you choose, the ambient temperature, patient's skin color, use of other coloring agents, and all this stuff can vary the derived CRT values. So if we look at the famous Andromeda shock trial, after which the CRT has been made popular, they had objectified the measurement of CRT with the use of certain glass microscope, exact amount of pressure measured by specific equipments, and video recording of the capillary refill time. So all this whether can be reproduced in our daily clinical setup is questionable. Nevertheless, I would say in a resource limited setup where you cannot measure lactate too frequently, you include CRT in your assessment, at least in the initial part of resuscitation, maybe in a 30 minutes basis. And on top of that, you measure lactate maybe every 1 hour or 2 hour basis, so that you can have the best of both worlds.
All right, so great. Now, the thing is, fluids will be going on simultaneously, vasopressin will be going on, and we have to reach a map of 65. But at
Right.
some point, we have to stop the fluids. And
Yes.
so there's a balance between doing fluids and vasopressors. Obviously, we give more
Yes.
vasopressors, the pressure comes up. So, where would
Yes.
you like to stop the fluids there?
Yes, so how to stop the fluid? We need to here use some objective parameters. So there are two things we need to consider here. Um Fluid responsiveness and fluid intolerance. So before going to that, obviously we first focus on our resuscitation endpoints. So the basic aim what we want to achieve here is that at least MAP of 65 or urine output of more than 0.5 ml per kg per hour. So once you have achieved that macro hemodynamic goals, with an ongoing fluid and vasopressor resuscitation simultaneously, we should keep an eye on whether patient is developing any signs or symptoms of fluid intolerance in terms of increase in the B profile in the lung ultrasound, or increase in the Vexa score or IVC diameter, all these parameters. So before achieving though, before reaching on those points itself, we should assess and reassess fluid intolerance. Sorry, assess and reassess fluid responsiveness. So once patient is no longer fluid responsive, then we need to cut down on fluid administration further, slow it down, and look for the signs of fluid intolerance. So for fluid responsiveness, we need to see the traditional parameters which you use. You may, depending on your availability and setup, when you have only ultrasound, you may use the IVC or the left ventricular parameters like VTI and all these parameters. And when you have advanced hemodynamic monitoring, you can use the pulse pressure variations or stroke volume variations. So once we know that the respective cutoff values like 10% or 12%, it is less than that, that means patient is no longer fluid responsiveness. So at that point of time, you should significantly cut down on the fluid administration rate and come to probably maintenance fluid if at all required. Otherwise, you completely cut down on fluid, and henceforth keep an eye on the markers of fluid intolerance.
Great, so thank you. So the last question about this would be about the antibiotics. So meningococcal sepsis is not common, but we get meningococcal meningitis at times, more
Yes, sir.
in children. So what antibiotic would be of choice here for meningococcal sepsis?
So antibiotic of choice will be ceftriaxone, and if there is suspicion of meningitis, vancomycin may be added to that. So that will be my choice of antibiotic. And in the context of septic shock, I will also advocate early administration of antibiotic as early as 1 hour if possible, preferably after obtaining the appropriate culture. However, in this context, it's important to note if we are not able to collect the culture in time, it should not be a cause for delay in the antibiotic administration.
Right, sir. So the other question now will be about other aspects of critical care. Recently, there have
Right.
been reports describing ammonic encephalopathy, which is occurring in patients who have
Yes, yes,
normal livers.
yes, yes. Mainly in
So
UTI.
this has been described especially in patients with urinary kind of problems, especially urinary
Yes,
tract infections. So would you like to tell about
right.
this, sir?
Right. So this has been recently described actually. So it has been found that and usually termed as non-cirrhotic or non-hepatic ammonic hyperammonic encephalopathy. So what happens? It has been found that especially in the setting of UTI, the urease producing bacteria, as if they are the causative organism, they will split urea and will generate ammonium, and subsequently in an alkaline pH will get converted to ammonia in the urinary tract, and that ammonia will be absorbed by the perivesical venous plexus and will reach the central circulation bypassing the liver. So this happens more commonly if there is some stagnation in the urinary tract in the setting of obstructive uropathy, and this ammonia can cause rise in ammonia level and subsequently encephalopathies. So in non-cirrhotic patients, in a sepsis patient, if we are having encephalopathy, if a patient in a patient with normal liver function, non-cirrhotic, we should not always label it just as a septic encephalopathy and may consider ammonia level to rule out an hyperammonic encephalopathy in this kind of clinical setup.
Great, sir. So now moving on to TAPSE. So we all
Right.
know about TAPSE, but there is also, something coming up as MAPSE,
Y-
MAPSE.
Yes,
So
yes.
would you like to tell about it, sir?
Right. So, TAPSE is tricuspid annular plane systolic excursion, and MAPSE is quite similar to that, the mitral annular plane systolic excursion. So, as a part of point of care echocardiography examination in the bedside, these are nowadays coming up. TAPSE has been there in use for quite some time. So, in TAPSE, we used to see the contractility of the right ventricle, mainly the longitudinal contractility. So, in MAPSE, what we do, the mitral annulus, we take an apical four-chamber view and put an M mode to the mitral annulus, the medial or the lateral annulus, and uh, see the excursion of the mitral annulus in the M mode and measure that. So what happens in apical four-chamber view? It indirectly tells us the longitudinal contraction of the LV, the apex to base contraction. So I think normal MAPSE value is about more than 10 or 12 mm. So if it is less than that, we considered a decreased MAPSE means suggesting decreased LV contractility. So it has got some diagnostic as well as prognostic significance. Mainly before global LV dysfunction sets in a patient with sepsis or septic shock pathology, MAPSE can, I mean, earlier detection of a low MAPSE can point towards the fact that probably the patient is going towards a septic cardiomyopathy, and that why it has got some amount of beta sensitivity, and it has got also prognostic significance. Some retrospective and prospective observational studies have found that a decreased MAPSE in initial period of time can suggest that patient may have higher probability of decreased decreased survival and other either was outcomes. But having said that, we must understand here that MAPSE will assess only the longitudinal contraction of the LV, whereas the major part of the LV contraction is the radial or the circumferential movement, which it won't take into account. So isolated measurement of MAPSE should always be interpreted with a lot of caution, and it can be part of the global assessment of the POCUS and global hemodynamic assessment, just an add-on information.
Nice, sir. Thank you. So the other question now is what fluids are recommended for patients with traumatic brain injury or with increased intracranial pressure?
Okay, right. So, usually in critical ill patients, we use crystalloids and most commonly the balanced salt solution, RL being the most common fluid being used in sepsis and septic shock resuscitation. So, in traumatic brain injury, we have specific concern on the use of any hypotonic fluid. So, if we talk about the crystalloid versus colloid, then colloids are almost never used in traumatic brain injury. In other patients, we can still use albumin as a colloid for resuscitation, but in traumatic brain injury, you can't even use albumin because it's known that albumin in a patients with deranged blood-brain barrier can cross inside and contributes to the rise in ICP. And the important trials, mainly the SAFE TBI trial, has also shown that there is significantly mortality increase in the albumin group when you have done a head-to-head trial with the normal saline. So, normal saline should be the fluid of choice in traumatic brain injury patients because it is isotonic or little bit hypertonic as compared to a traditional balance salt solutions like RL, which is a bit of hypotonic. So yes, RL is not a contraindication in traumatic brain injury, but the predominant crystalloid of choice will be normal saline in traumatic brain injury or raised ICP.
Right, sir. Now, final question is a clinical question. this is something which actually happened in our ICU also. So in the morning the patient got up. He was under sedation for a few days, and when he got up, he started saying that the nurse was beating me up, he was stabbing me, and blood was
Yes,
coming out, and it became a very big issue. And he
yes,
told his relatives, and it was a very big issue, as you can understand. But we convinced him somehow that this is not the case. So, sir, what really happens in these patients who are on sedation, and then you stop sedation, they're on the ventilator, and they get up and they can, feel like this and communicate like this. What
yes,
exactly is
yes.
this?
So, what you described is a common scenario, and it happens with many patients. So, the typically what you described is basically a visual hallucination or a auditory hallucination is happening. So there have been significant amount of data coming up in from various parts of the country, various parts of the world in ICU literature, as well as in our clinical experience. We are seeing that the hallucinations are occurring, or I would say rather identified more commonly nowadays, and it can be considered as a spectrum of hallucination leading to delirium. So ICU delirium is already a known entity and a big entity. It's very, very common. Now, hallucination, as per reported literature, is not so common, maybe because it has not been identified properly, or maybe we did not have proper awareness of this phenomena. Now, if why this happens, we have to identify and tell properly. We do not yet have clear understanding. But if we look at the risk factors, mainly it has been researched in the fashion of questionnaire or interview of patients who have been discharged from the ICU, and you find out whether or how they have hallucinations. And secondly, in certain prospective trials, people have tried to identify in the bedside if the patient is having any hallucinations or not. So the certain risk factors are lack of proper sleep, lot of sensory input, lack of sleep hygiene, and lot of noise like alarms, noise, and inappropriate timing of suctioning, other painful stimuli. So, and also the inadequate sedation level, improper management of sedation and analgesia in the ICU. So, however, grossly these are the risk factors, but more important question is how we can detect it better and how we can prevent it better. So in that context, first of all, you need to raise an alarm among ourselves that what are the patients at risk. So the patients who are already having a known psychiatric or neurological disorders, patients who have known liver disorders, patients who are in younger age, patients who are likely to stay in ICU for a longer period of time, specifically on mechanical ventilator for a longer period of time, they are at higher risk. And then their sedation and analgesia management has to be absolutely titrated to our specific targeted endpoints. For example, use the rash scoring properly, or use, even if possible, the process neurophysiological monitoring properly, the electroencephalograms properly, to provide analgeo first sedation, and then you improve the patient's other by non-pharmacological methods, improves patients acceptance in the surrounding environment. So more frequent patient visits, more and more communication to the patients whenever he or she wakes up, use of specs in the patients who have been using specs before, use of hearing aids to the patients who have been used to that. In the night, use of eye patches, use of earplugs, maybe use of light musics, dimming the lights, reducing the level of noise of alarms in the ventilator. So all these things will be much more helpful. And repeated communication and counseling to the patients, and trying to pick up the early these kind of problems, hallucination or early signs of delirium early, by specifically using certain questionnaires like CAM-ICU questionnaires. So these will be the key to manage this kind of scenarios. However, we need more data before we can talk robust in a robust manner on this aspect.
Yes, sir. Thank you. I think it's very important for everybody here to realize that what this is, and
Right,
address it properly, because this becomes a very big issue with the family members.
right,
It is saying nurse was thrashing me and stabbing me and drawing blood, and
Right.
so one has to be aware of this and manage it
Right.
accordingly. So, as
Right.
Dr. Dalim Baidya sir, thank you very much. That was wonderful talking to you, and you have been educating everybody. Wonderful audience, and I thank the audience for joining in for the patient hearing. Hope they had great learning. Thank you, sir. See you again sometime.
Thank you so much. Thank you.